Hello and welcome to Module 1 of your LNEC course. So this Module 1, the Introduction to Palliative Care, is going to be a 3-section module, and this is your first of the 3 modules. By the end of these 3 modules, the 3 separate video recordings, you're going to be able to describe the role of the nurse in providing palliative care, as well as the philosophical principles of hospice and palliative care, and you're going to be able to tell the difference between those two and how they affect the quality of care at end of life. You will also be able to discuss aspects of assembly and psychological, physiological, spiritual, and social domains of quality of life for patients and families receiving palliative and hospice care. Now, there are various domains within the palliative care continuum, and the National Consensus Project, the NCP, has 8 domains, and we're going to talk about each of these as we're going throughout. So we have in domain, the structure and process of care, we have the interdisciplinary team. Because palliative care and hospice care are holistic and so complex, it is absolutely critical to incorporate an interdisciplinary team. This is not the role of the nurse, it is not the role of the physician, it's not the role of the social worker. We need everybody bringing their expertise in order to improve quality of life for the patient and the families. There's also comprehensive palliative care assessment. So an interdisciplinary comprehensive assessment of the patient and family really forms the basis for the development of an individualized patient and family palliative care team. And with palliative care plans, it's a collaboration between the patient and the family for the interdisciplinary team to be able to implement and enact and update the care plan. It's necessary to be able to anticipate, prevent, and treat physical, psychological, social, and spiritual needs that may arise. And so that's the plan. How do you address each of these different aspects? And then palliative care is really a continuum. So the interdisciplinary team has defined a process to ensure that access, quality, and continuity of care occurs, especially during transitions of care, which we will discuss more throughout. The care setting is really where that care is provided. This is no longer provided just in the hospital in the acute care setting. The care setting extends to private residences, assisted living facilities, rehab facilities, skilled and intermediate facilities, acute, long-term, clinics, correctional homes, homeless shelters, the VA. The care setting is really vast, and that is another reason why you need your interdisciplinary care team. When talking about interdisciplinary team education, it's really important to have education, training, and professional development available to the interdisciplinary team, because for them to provide this comprehensive holistic care in these really unique care settings, this is a continual learning process, and so it's important to maintain that education and continuing education of the care team. So there's also coordination of care and care transitions. So care is coordinated and characterized as a right of care, the right care at the right time for the individual throughout the course of their disease or condition. And in talking about right care at right time throughout the course of disease, obviously that's going to change. And so you have to go back to that comprehensive palliative care assessment. Emotional support and interdisciplinary teams. So providing palliative care to patients with serious illness and their families has a huge emotional impact. So the interdisciplinary team needs to create an environment of resilience, self-care, and mutual support. And we will really be talking about self-care and how to care for yourself not only throughout your nursing profession, but especially when you're providing palliative and hospice care to your patients. Stability, sustainability, and growth. So it's important to recognize the limitations in reimbursement for the interdisciplinary palliative care team, because for this to be sustainable, it needs to be long-term. So we are going to talk a little bit about who pays for hospice care, who pays for palliative care, and what does that look like, not only on a systems level, but also on the individual patient and family level. So these are some important things, the structure and process of care. It is complex, and there are those various aspects to it to really make palliative care possible. So let's look at Amy. Amy is a 72-year-old who has a history of diabetes, hypertension, and renal failure. She drives 25 miles one way every other day for dialysis. Her 40-year-old physically disabled son, who is unable to work or drive, lives with her. She has no other children. She's widowed. She's not religious, but she does call herself spiritual. 4 days ago, she had a stroke, and now she has left-sided paralysis. She will be discharged to a rehab center in the next few days. She has no advance directives and has refused to sign a DNR. So, would palliative care be appropriate for Amy? And if you think that it would, what role could palliative care play within her care? Could she qualify for hospice? What interprofessional team members would you want to include in her care? Besides her physical needs, what other needs may she have? Psychological, social, spiritual? What about caring for her disabled son? What are some potential ethical issues that you might envision in the future for Amy? Things like prolonging life versus promoting suffering, withholding or withdrawing medical interventions, medical futility, and why is she refusing this DNR? So this is a really typical aspect of patients that you will see who could really benefit from palliative and hospice care. Now let's talk about death and dying in America. The nurse plays a very, very major role in caring for the seriously ill patient as well as their families. So it's the nurse who's able to elicit the goals of care, to assess, manage, and coordinate care, to listen to what it is the family and the patients need. Bearing witness is also a very, I can never think of a good word to describe it, but bearing witness to somebody's suffering, bearing witness to their death, it's a very, it's an honor, really, to be there with the patients and their families as they are dying. Because if you think about it, dying is a very intimate, very, very intimate piece of somebody's life. It's the moment that life no longer is. And so to be there and bear witness to that is really a unique aspect of nursing. Communication is huge within the nursing role and the palliative care team. You have to communicate with the different members who have their different expertise in their own languages. You have to be able to communicate with the family and help the family understand what's happening. And then it's very important to be knowledgeable in evidence-based practice. So some facts about dying in America today. So 60% of adults live with at least one condition, with 40% of those 60 with 2 or more chronic conditions. So think about that. 60% of those living with at least live with at least one chronic condition, and of those 60, there's 40% who have 2 or more. Over 2.8 million individuals die each year in the U.S., and leading causes of death are heart disease, cancer, unintentional injuries, chronic lower respiratory disease, and cerebrovascular accidents or stroke. I will say, in my experience, heart disease and respiratory disease are the 2 big ones that I see all the time, and a lot of times they occur concurrently. So it's a balancing act to manage the symptoms of heart disease, heart failure, and of COPD. There is a huge impact on care with serious illness in the U.S., and one of those is cost. So healthcare spending in the United States hit $3.8 trillion in 2019. So that was 3 years ago already, and we're almost to $4 trillion. 90% of healthcare spending goes to treat chronic conditions and mental health illness. So in thinking about that, that's only 10% is things like acute injury and unexpected injury. Medicare spending will increase with the number of baby boomers coming into the system, so we all know that is kind of looming over our heads. How are we going to provide care to this population? Failure to treat pain and symptoms remains a major health issue due to lack of education about pain, symptoms, and management, which we are going to talk a lot about pain and symptom management throughout this LNAT course. And then technology is really more refined than ever before. So while it is used to prolong life, it may not always restore life, and it may rather promote suffering. So these are all impacts on care, impacts on the individual within those with living with serious illness. So it's important, obviously, to manage costs. And how do we manage costs? How do we talk about other issues like ethical consideration? Better communication is going to be the number one way the nurse can help with these things. So managing the symptoms is going to manage costs. Managing symptoms is going to help do the most good for the patient, and that may become an ethical issue if that is not being done. So if we're talking about, remember, autonomy, beneficence, non-maleficence, justice. Autonomy is allowing the self to be individual. Beneficence is doing the greatest good. Non-maleficence is not doing harm. And then justice is that fair allocation of resources. So impact of chronic illness on patients and families. The one thing I really, really want you to think and ask yourself constantly with every patient that you care for, are you prolonging life or are you promoting suffering? What is the burden versus benefit ratio? As you ask yourself, benefit versus burden, prolonging life versus promoting suffering, we're talking about quality of life, especially at the end of life. Palliative care consult teams who interact both inpatient and outpatient found that symptom management was really the foremost in the conversations, followed by discussion of emotional aspects of disease. So by ensuring that if there's a clear patient and family communication, then you can really help to promote that psychosocial support that helps to relieve pain, dyspnea, nausea, and other distressing symptoms, because symptom management really, again, is the foremost importance to the patient and their family members, especially at end of life. That promotes quality of life. So symptom management is very key. It's also been noted that patients want to achieve a sense of control for as long as they can to attain some sort of spiritual peace, to succeed in having their finances in order, strengthen relationships with loved ones, and it's really important for them to believe that their life has meaning. So this is another aspect of quality of life at the end of life, is that meaning, that existential component, and having that sense of control, finding that spiritual peace. Here are different timelines for disease trajectories for health status and death. So illness, if you look at sudden unexpected death, the disease and dying trajectory really illustrates differences in the dying experience by examining the duration of the dying process and the course of the disease or injury. So as you can see in that top left diagram, a sudden death, an unexpected cause such as an MI or a car accident, something like that, you have this health status, the event occurs, and then there's death. So it's a very sharp, sudden death that occurs with that sudden death, hence sudden death. In that next top one, the top right, is talking about steady decline in short terminal phase. So there is the health state, there is that illness, and then there's a steady decline into that death. So an example would be something like pancreatic cancer, something that has a very short terminal period. Now on the bottom left, chronic illness, this one is going to look a lot different. So with chronic illness, there are periodic crises, and then there is death. So especially things like COPD, heart failure, liver failure, AIDS, there's going to be these stages of health, a sharp decline where there's acute crisis, and then it'll pop back up. Then you've got health, and then you've got another crisis. So you're gonna have a sharp decline in health. But notice that after each of these declines, when they come back to a state of health, that state of health is not the same as it was. So while these acute periods are followed by health, the level of ability or the functionality of the patient is not going to be the same. They're not going to have that same level of health state. And then there's that progressive deterioration or expected death. So this is lingering and expected death, especially seen in older adults who are declining with no really specific cause. So there's that prolonged, gradual physical and cognitive decline with increased fatigue, weight loss. There's changes in food and fluid intake, multiple comorbidities, and then eventually that'll come to death. So this is especially difficult for caregivers. So it's important to think about that family and who's providing care. Is this person being cared for at home by a child or a grandchild? How is that occurring? So those are the different trajectories with different disease states. So you've got your sudden and unexpected. You've got a steady decline with a short terminal phase. You've got chronic illness with those periodic crises. And then you've got that progressive deterioration with expected death. Now, in talking about the caregivers, it's really important to look at the cost to the caregiver. And there's this running joke that is, I mean, we laugh to keep from crying, basically, but the caregiver is sicker than the patient that you're caring for, typically. So the caregiver, it's a huge toll to provide end-of-life care and palliative care and hospice care. The majority of adults prefer to die at home. Shocker. But because they prefer to die at home, typically this requires a family member to provide support. And family members account for approximately 80% of the care. Now, this is care 24 hours a day, 7 days a week. So if you think about your brief stint in long-term care or whatever your most recent clinical rotation was, you got to go home after the end of your 8-hour or 12-hour or however many hour shifts, and you got to recuperate. But the caregivers, they don't get to go home. They're there providing care day and night, and so it's incredibly taxing. It can be very rewarding and often is for families, but as a nurse, we need to remember what the caregiver is going through. The caregiver, they typically have a sharp decline in health as well. There tends to be multiple financial stressors, and it's important to also remember their physical, psychological, social, and spiritual angst. So what makes up a family? We talked about, for those of you who were in 301 with me, we talked about the family being who the patient says it is, and it's no longer the nuclear family of a man and a woman and their 2.5 kids in their house with a white picket fence. It can be someone who's not related by blood. It could be a grandparent and a grandchild. It could be an aunt, an uncle, a cousin. It can be anything. So when you're talking about family, you're not talking just about who is related by blood. It's who the patient describes as family. Now, the caveat I will say, it is very, very important to include whoever is defined as family by the patient, but unless there is a legal designated caregiver that is not by blood, it has to be legally designated. You cannot have someone who is not related by blood making these big decisions until you've exhausted all of the other channels. So that's another thing that we'll bring up in ethics, but really the important thing to remember is, family is who the patient says it is, so you take care of that family unit, and just keep in mind the legality of it. Veterans are a very underserved population, so I do just want to throw this out there really quickly, especially at the end of life. It's important to think about what the veterans need, what they've gone through, what they're experiencing, because not only are they underserved, they're a unique population that have some very unique needs, especially those psychosocial needs. So to wrap up, throughout this, we're taking care of people during a very difficult time of their lives, maybe palliative, maybe hospice, maybe end of life, those last few days, those last few moments. Always ask yourself, are you prolonging life only to promote suffering? Or are you, in your prolonging life, are you promoting quality of life? And what is that burden versus benefit? So that wraps up the first section of the Introduction to Palliative Care in the LNEC modules. Write down your questions, we'll discuss it in class.